the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope the podcast empowers men with the knowledge and confidence to address their issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in today's episode, we discuss knee pain, a problem that most men will experience at some point in their lives. Most of the time, the problem can be solved by simply taking a pain reliever. But what if the pain keeps coming back? How can you prevent it from getting worse? What non-invasive and minimally invasive treatment options are available? And when is it time to start considering surgery? We presented these questions to orthopedic surgeon Dr. Erik Zeegen. Dr. Zeegen attended UCLA and UC Berkeley as an undergraduate. He then graduated from the UCLA Medical School and completed his residency training in orthopedic surgery at UCLA. After residency, Dr. Zeegen completed an Orthopedic Surgical Oncology Fellowship at Mass General Hospital in Boston, and then an Adult Reconstructive Surgery Fellowship at the New England Baptist Hospital. After his training, Dr. Zeegen returned to Los Angeles, where he served as the Associate Medical Director of the Valley Hip and Knee Institute until recently, when he was named the Chief of Joint Replacement Surgery at UCLA. And now, without further ado, I bring you our conversation with Dr. Erik Zeegen about managing knee pain. Hello and welcome to the Better Man Clinics. Today we're going to be talking about knee pain, a problem that affects most men at some point in their lives, and a problem that can be quite debilitating. It can keep guys from doing a lot of the activities that they enjoy, like working out, playing sports, or even going for a hike. And for some guys, it's debilitating enough that it keeps them from doing their daily activities or going to work. So today we're fortunate to be joined by a true expert in the field, Dr. Erik Zeegen, who's not only a licensed and board certified orthopedic surgeon, but he also heads up and is the chief of the joint replacement program at UCLA. So Dr. Zeegen, welcome to the program.
Thanks for having me, Oleg. Nice to see you.
You too, absolutely. Before we dive into the topic, I want to first ask you a little bit kind of about yourself. I've kind of pre-introduced you, but I always wonder, what inspired you to A, go into orthopedic surgery, and B, specifically focus on helping people with joint problems like knee pain, et cetera?
Well, like a lot of physicians, my father is a physician, so I think it started at a pretty early age, seeing my dad, doing what doctors do, which is taking care of patients. So from a very early age, that it was just kind of right there in front of me. But then growing up, I was an athlete. I played soccer pretty competitively and had pretty typical injuries, meniscal tear, broken ankle, and a couple of concussions. And so, that kind of got me interested in orthopedics. And then when I was a teenager, which now seems like a long time ago, but
doesn't it though? Right?
I was interested in surgery and wanted to go watch my dad do surgery, and so I would go. But after a few minutes of watching, my father's an ophthalmologist, so watching cataract surgery just wasn't quite doing it for me. And one of his good friends, who was a med school classmate of his, is an orthopedic surgeon and would always be down the hall doing some hip or knee case. And I always just ended up in his room watching him do surgery rather than my dad. And,
Got it.
I think I knew pretty early on that that's what I wanted to do. So that's kind of how I got into it.
Awesome. Never looked back then. That's fantastic.
Yeah.
So, as we talked about, today we're going to talk about knee pain, which is right up your alley. And, the first question is, people get knee pain and they don't really know what it could be from. And I know there's a gamut of things. We're not going to go through everything. But when you hear knee pain from a patient, what are the common things that go through your mind as potential causes?
Well, first off, just to make it clear, I have a subspecialty, as you mentioned, in joint replacement surgery. And because I'm at UCLA and have a pretty specific practice for joint replacement, most of the people coming to see me these days have pretty significant arthritis and are there to discuss knee replacement surgery. But if we're gonna kind of, focus a little more broadly on the
Sure.
whole spectrum of knee pain, I can put on my just general orthopedic hat and we can
Yeah.
discuss that. But knee pain can be as simple as just a sprain or a strain, which really just means some of the soft tissues around the knee have been injured to a minor degree, to people with more significant soft tissue injuries like a ligament tear, probably the most common injury to the knee in sports related activities is the ACL being torn. A lot of athletes have ACL tears. To meniscus tears. The meniscus is the cartilage that sits between the two bones of the knee, the femur and the tibia, and patients can have a tear of the meniscus. To problems with the kneecap, the way it tracks, what we call patellofemoral syndrome, or patients can have irritation of the thick band of tissue on the outer side of the thigh that runs down to the knee, which is called the iliotibial band, and they can have iliotibial band syndrome. To arthritic conditions like I was mentioning before, most commonly is osteoarthritis, but then there are other subtypes of arthritis like rheumatoid arthritis or psoriatic arthritis or other what we call inflammatory arthritis conditions. And then there can be traumatic injuries like fractures, subluxations or dislocations, to less common things like infections or tumors. So that kind of runs the whole spectrum of things that we can see wrong with the knee.
Well, that does provide a pretty comprehensive view. And I guess the first question, which is probably one of the more important, I should say, what are those red flags that for a guy out there who either with chronic knee pain or acute knee pain that makes them think, you know what, I should go see a doctor pretty acutely versus, it's some chronic thing, I'm going to ice it and relax and stuff. What are those key red flags that they should look out for?
Yeah, that's a good question. A couple of things that we really try and be aware of are significant swelling of the knee. So if your knee is pretty normal and all of a sudden it's 2 or 3 times the normal size of your knee, that's something that probably ought to be looked at.
Mm-hmm.
If the knee is warm and red or hot, that could be a sign of an infection. If you can't put weight on it, that's indication that there's something pretty significant going on. Or if you can't straighten it out all the way or bend it, that would be another indication of something pretty acute going on.
Right. So yeah, those are great tips to look out for sure. Now, if we take aside all of the acute things, like you mentioned, ACL tears and meniscus and stuff like that, like or I don't know if meniscus is really acute, but the
Well, it can be. It can
yeah.
be.
So
it
if you
can
take, sorry, go ahead.
No, with the meniscus tears, you can have a chronic meniscus tear, or you can have, what's called a bucket handle tear, which is a pretty significant tear of the meniscus where it looks like an actual bucket handle, and that
Oh, wow.
piece of meniscus flips into the central notch of the femur, and then it precludes the knee from straightening out all the way. And that can be an acute issue.
That sure sounds like it. If we take the acute knee injuries out of the picture, and we're talking about chronic conditions, like you mentioned, arthritis or others that are more chronic, a few things just to back up. Let's say they're, somebody, it's not bothering that much. It's just kind of a little irritating. Are there any specific activities that for these type of chronic conditions would make knee pain worse?
Well, I think high impact activities certainly can put a lot of stress on the knee. So things like running, jumping, even deep squats can put a lot of force on the knee. When you look at kinematic studies, we we can do this in the biomechanics lab. We can measure how much force is on the knee. And just walking, everyday walking, doesn't put that much stress on the knee. Probably about half your body weight goes through the knee. But if you start doing things like jogging, now you're up to about 7 times your body weight going through your knee. And if you're doing a deep squat, up to about 20 times your body weight going through your knee. So those types of activities can put a lot of stress on the knee. And then if you compound that with somebody who is carrying extra weight, which is typical in men as we get older, it becomes harder to, keep our weight that we're at in our 20s. That then exponentially increases the amount of force on the knee in those particular activities.
No, that's a good point. You kind of run into this kind of, catch 22, right? You get older, everyone tells you go to the gym, go work out, but then your arthritis in your knee or your condition starts bothering you. You're like, I can't work out, but it's bothering me, right? So you can't win. But you brought up an important point in terms of weight, right? So my next question was kind of going to lead in that direction. Like, what can guys do to potentially mitigate the knee pain? Again, we're talking about chronic, mild to moderate, nothing major, to mitigate that type of knee pain from getting worse. Like, I would assume weight loss would be one of those things, right? Because there's less strain on the knee. Is that correct?
Yeah, absolutely. Absolutely. Like I just mentioned, went through those different scenarios of how much weight is going through your knee. So if you're carrying an extra 10 pounds, even that little amount, which doesn't seem like a lot, if you're going out jogging, now that's 70 extra pounds your knee is seeing in force across the joint, which is pretty substantial. So I think keeping your weight optimal is one thing. I think as we all get older, it's really important to listen to our bodies. So if you go out and, and this happened to me personally, I used to be a runner.
Yeah.
And, a few years ago, I started realizing I just couldn't run, 4 or 5 times a week. Because if I was doing that, my knees, my back would really start hurting. I'd be in the OR the next day, and it was really a struggle. So I started mixing it up, incorporating, low to non-impact activities into my exercise regimen. So you have to be smart about it and listen to your body. And so now, I may run, 1 or 2 times a week, and ride a bike. I have a Peloton, which I use, and incorporate that, and then hiking a little bit more, and which is low to non-impact. So I think doing that, plus I think doing some sort of resistance exercise. It doesn't have to be massive amounts of weights, but some sort of resistance exercise, either with bands or light weights, to keep your muscles strong, particularly in the lower extremities around the hips and knee. Really takes some of the stress off the joints.
So again, that's great. So a couple of follow-ups for that. So first, in terms of low impact, you mentioned things like bicycling, swimming, stuff like that. Anything where you're not putting a lot of pressure on that knee, you're still getting a good workout, but you're not overstraining your knee. Is that correct for those low impact exercises?
Correct. The kind of simple way to think of this, which I tell all my patients, is any activity where you always have at least one foot on the ground is ideal. Because if you think about it, the difference between walking and running is when you're walking, one foot is always on the ground between each step. When you're running, there is a moment in time between each step that the body comes completely off the ground, and it's that impact that really creates that jarring force on the knee. So anything where both feet come off the ground is probably going to impart a lot more stress on the knee, like we talked about.
That's a great visual. I mean, I think of those cartoons, when they're kind of running around, they're like up there, but it happens to all of us, I guess, when we're running. Similarly, you mentioned strengthening exercise. So I'm assuming like strengthening the hamstrings, the quads, those type of exercises, because the idea there is the muscles around the knee are preventing it from getting the impact, or just strengthening it when it gets impacted. Like, what is the mechanism behind helping there?
Well, by the muscles being strong and really in shape, it takes some of the stress off the knee itself, and the muscles can stabilize the knee so that during any of these types of activities, if there's any instability of the knee, that can lead to shear forces and stress to the articular cartilage and meniscal cartilage. And if your muscles are nice and strong and keeping that knee stable, there's less chance of that happening.
Makes
But
sense.
in resistance exercises, it's important to understand there's different types of resistance exercises. And when we're talking about the knee, there's what we call open chain or closed chain exercises. And think of your leg as like a chain. And if your foot is free, meaning not on the ground or pushed up against something, that's considered an open chain.
Mhm.
And so the key exercise I tell most of my patients to stay away from are the knee extensions. We've all seen those at the
Yeah.
gym. You sit at the chair and you put your foot on the lever and you extend your knee against the weight. And you think, oh, this is great, I'm getting a great workout for my quadriceps. And it is, but at the same time, if you go back to basic physics, your foot's free, you have a weight at the end of your tibia, and you
Mhm.
multiply that by the lever, and now you have a huge torque on your knee. So
Yes.
if you compare that to, say, what we call a closed chain exercise, which is where your foot is against the ground, like doing squats or
Mhm.
leg presses, now that torque is eliminated, and it's just a force being dampened through the tibia, and you're still getting the workout on your quads and hamstrings without that huge torque. So doing those types of exercises is definitely a better idea. But with the squats, you want to be careful. You don't want to be doing deep squats. I tell my patients, think of your knee at about 45 to 60 degrees and doing a squat and stopping there, not
Mhm.
going all the way down.
Not go all the way down. Got it. No, that's great advice. Because before you said that, I'm like, well, lower extremities, and go ahead and start doing those knee, those leg extensions. But I'm
Yeah,
glad
I
you brought that
generally
up.
tell people to stay away from those, but partial squats and leg presses are great. And then
Fantastic.
hamstring curls are okay. That's kind of the opposite of the knee extension, but that even though the foot is free with that, it's not putting a huge torque on the knee as is the knee extension.
Got it. One thing you hear a lot online about protect your knees is shoes. Wear this type of shoe or that type of shoe. Do you subscribe to that? Is there a better shoe? I mean, I'm not talking about a specific brand or anything, but is there truth in the fact that shoes make a difference if you're running or walking to protect your knee? And what element of the shoe is doing that protection, if so?
I don't know of any data that shows that there's any particular shoe that makes a difference,
Mhm.
um, for knee pain or knee arthritis. And I get asked the question periodically, and I just tell patients, just common sense. You want to have a shoe that's comfortable, that provides good support. Um, if you have a shoe that is causing pain in your foot or feeling like it's throwing your gait off and making you walk differently than you normally do, it's probably not a good shoe to be
Yeah.
wearing.
Like high heels, stuff like that.
Yeah.
I try to stay away from those. So I want to play a game with you in terms of like kind of true or false, right? So you hear a lot of home remedies and I don't, again, this is for chronic, mild to moderate. I don't mean like when your knee is the size of a watermelon, just, dealing with chronic pain where you're not quite ready to go to the doctor. It's just kind of bothering you a little bit. And you hear everything from your buddy to online, like try this or that. So simple things, I'm assuming like ice or heat, no harm there. Pretty good advice for knee pain.
Yeah, I mean, it falls into that, what we call RICE, rest, ice, compression, and elevation. So ice is, for an acute injury, if we're out playing basketball and you twist your knee and it hurts, putting ice on it right away is definitely something that we recommend.
Mhm.
And ice is good because it's cold. It decreases the inflammatory response and can be very helpful for an acute injury. Heat is good later on, maybe a couple of days later when you're in a little bit more of the recovery phase. The acute inflammation has settled down and you're trying to get the knee moving a little more comfortably. The heat will do the opposite. It'll cause some vasodilation, bring some more blood flow to the area, and just help kind of loosen things up a little bit.
Makes sense. Now, one thing that I always get confused by, because I get pulled in every direction, is activity. And now, not talking about an acute injury, but like, let's say you have chronic arthritis of the knee, it bugs you periodically. Some people say, get more active and you'll kind of work it out. And other people say, well, if it's acting up, take it easy. Don't do much activity. Let it relax a little bit. Is it some combination thereof? Where do you stand with that?
Well, every patient's a little different, but I think in general, it kind of goes back to what we were saying, which is that if you do have some pre-existing arthritis in your knee, you want to be smart about how you're being active. And
Mhm.
so you want to pick activities that are low to non-impact. You certainly don't want to be a couch potato, because not being active will decrease the muscle tone.
Mhm.
We need to be weight bearing for the strength of our bones. We know that if you're not stressing the bone, then bones can become more osteoporotic, which is not healthy. So we generally recommend, even for patients who have advanced osteoarthritis of the knee, to try and stay as active as possible, but just be smart about it and stick with low to non-impact activities.
Got it. Now, this next question is going to be a little bit tricky because it really does depend on the patient and other medical conditions and all that. But let's just take it on a high level. The question of NSAIDs, right? Motrin, ibuprofen, Mobic, you name it. It often becomes the best friend of people with chronic pain, like knee pain or whatnot. And I don't know if there's a right answer here. So when is it like when a guy should say, you know what, I'm relying on this too much. I really need to get help, right? I can't just keep using NSAIDs as a crutch for my pain. Do you have like some kind of magic number in terms of how often they use it or how long they've been using it before they should really seek help, that this is not the answer?
Yeah, as you said, I mean, every patient brings a unique set of circumstances to the
Mhm.
situation, but I think, and there's no real hard number to
Right.
go by, but generally, when patients come in and they tell me they've been taking 600 milligrams of ibuprofen 3 to 4 times a day for months on end, that's
Correct.
somebody I'm worried about, because, as you know, the non-selective, non-steroidal anti-inflammatories, like the over-the-counter things like ibuprofen, naproxen,
Mhm.
those can have a significant effect on your renal function. As a urologist, you're well aware of that. And,
Right.
it can raise your blood pressure. It can cause problems with the gastrointestinal tract, so people can get ulcers or bleeding ulcers that can become really significant. There's been many cases we've heard about of patients who have severe osteoarthritis and are popping tons of ibuprofen. They develop a bleeding ulcer, and that becomes an acute problem. They come in with significant blood loss, and it's almost a life-threatening condition. Now,
Yeah,
those are extreme cases, but it
sure.
is something you want to avoid. So when somebody comes in taking that much anti-inflammatories, then it's time to have a discussion about alternative treatment modalities to try and deal with their arthritis.
Got it. So it should be kind of as needed, not a vitamin,
Yeah,
basically.
I mean, it shouldn't be, yeah, exactly. It shouldn't be taken daily, for
Right.
months at a time.
Exactly. Now, flipping from the very common like NSAIDs to other things that you see advertised a lot, and I know guys, a lot of them rely on it, like supplements, dietary supplements. One of the most common, which I don't know if it's still in favor, we hear a lot, as I see a lot on my own patients' medical list them as glucosamine, chondroitin, specifically for knee pain. They're using that. What are your thoughts on that, or do you have it?
Yeah, I mean, it's a huge industry. I mean,
Right.
there's tons of money spent in the United States on these products, and there's a lot of hype about it, and it's been studied pretty extensively. If you look at the data, it's very soft. They've done a lot of systematic reviews and meta-analyses looking at all the different studies out there, and there's some suggestion that if you take the stuff for like 3 months or more, you may see a very mild improvement, but again, it's a soft call. I think when we look at data and we're talking about statistics, something can be statistically significant in terms of there being a difference between these remedies and, say, a placebo.
Mm-hmm.
But is there a meaningful clinical difference when you look at some of the scoring systems that we use to really objectively say, is somebody's knee pain better or worse than placebo? And there's really no clinically meaningful difference.
Mm-hmm.
So, when you look at the guidelines put forth by the American Academy of Orthopedic Surgeons, the glucosamine and chondroitin sulfate are not recommended for use for severe osteoarthritis of the knee.
Got it. So probably not the best use of their money to do that. Similarly, the another thing that I see advertised a lot, especially more recently, are these tapes. I know they're mostly used for sports, and you see the athletes wearing them, like all kinds of funny designs and
like
stuff.
The kinesio tapes.
Exactly. What are your thoughts on that?
I mean, again, it's something that patients come in all the time with. A lot of the physical therapists are big believers in it. My feeling is that it really, there's no harm in it. I don't know that there's a lot of hard data to say that it makes a difference. So
Mm-hmm.
I tell patients, if you feel it's helping, by all means continue it, but I don't know of any data to show that it makes a big difference.
Got it. And that really leads naturally to the next question. A guy has tried all of these things. It's getting to the point of like, it's not really working all that well. Is there a right time to when you should really see a doctor about this knee pain? Is it just kind of when you're sick of it? Like, when do you see people mostly? I mean, I know you're kind of at the end of the road, and we'll talk about that in terms of surgery, but like, when is there a right time to see a doctor about knee pain, aside from the red flags that we mentioned?
So I think when it becomes really intrusive into somebody's life, it's time to seek medical attention. So, and for every patient, that's kind of a unique set of circumstances. So for some people, it's when they have difficulty going up and down stairs and they live in a 2-story house, or
Mm-hmm.
if they're a golfer and they can no longer play their 18 holes of golf 3 times a week, or somebody who's a cyclist and can no longer do that
Mm-hmm.
ride that they want to do, or they can't pick up their grandchild, or all different types of set of circumstances. But basically, when the things that you are used to doing are no longer tolerable because of the knee pain, that's a sign to go see a doctor. And then just activities of daily living, if again, going up and down stairs, bending down to pick something off the ground, putting your shoes and socks on, if those things are becoming difficult, it's time to see a doctor.
Got it. And so one of the reasons why I put this podcast together is that guys, as you know, are pretty reluctant to go see a doctor. And one of the things that helps them is to understand what they should expect when they go see it. So when somebody sees you, or even the primary care doctor, when they're first coming in for knee pain, what does a typical evaluation of the knee even involve? Like, what are you doing to evaluate it at the doctor's office?
So there's a couple things. One is, as you know, with any doctor visit, is taking a good history. So listening to the patient, hearing what's going on, because you can get a lot of information just from the history.
Mm-hmm.
Does it hurt when you're just walking? Or does it hurt only when you flex the knee to a certain way? Does the knee feel unstable? So right away I'm trying to differentiate all the different things that can be going on. So taking a good history, then an exam, which involves watching the patient walk up and down the hall, see their gait pattern. Are they limping? Is there a deformity to the knee? That kind of thing. And then examining the knee,
Mm-hmm.
assessing the range of motion, the stability of the knee. We're checking the cruciate ligaments, the ACL to PCL, as well as the collateral ligaments, and then doing provocative maneuvers to see if there's any potential meniscal injury, assessing the kneecap or the patellofemoral compartment. So there's a lot of things we can do pretty quickly to get a good sense of what's going on with the knee. And then some sort of imaging modality, which usually starts with a plain X-ray.
Mm-hmm.
And then we can get more sophisticated if need be with an MRI or a CAT scan if need be.
For the when you're not worried about ligament tears and stuff like that, meniscal injuries, what do you like? If you think it is kind of just arthritis, is imaging still important, and what are you looking for in that situation?
Yeah, imaging is very important. I mean, I rely on it quite a bit. So what we're, and the key thing is we want to get weight bearing x-rays. So a lot of times I see patients that come in to see me and they've had x-rays elsewhere, but they weren't weight bearing x-rays. And you can see dramatic differences in the joint space between a supine non-weight bearing x-ray versus a weight bearing x-ray. And so what we're looking for is to see how much joint space there is, as well as radiographic signs of arthritis. And so if we start to see those things, then we know that somebody has more significant osteoarthritis of the knee. But we're also looking at, just kind of the gestalt view of the knee, looking at the overall alignment, the quality of the bone, the osteoporotic or not, ruling out any other acute things like fractures or dislocations. So we can get a lot of information from just a plain x-ray.
And again, just to clarify for the lay people listening, so weight bearing means they're just standing up. Basically, they're not actually lifting weights; they're just standing up versus laying down on a table, basically, right?
Correct. So yeah, sorry, I should have been more clear, but yeah, just standing up.
Got it. Perfect. So once you've kind of evaluated them and, you've come to a conclusion, obviously there's different diagnoses, but again, going with that chronic arthritis type of situation, I want to just get your thoughts on a few non-surgical options first, in terms of that you hear people referred for. One of them I hear a lot is physical therapy. Go get some physical therapy for your knee. What's involved with that, and what are your thoughts about its efficacy?
I'm a big believer in physical therapy. I think it definitely helps. It goes back to what we were talking about earlier with, just generalized strengthening of the muscles to kind of tighten things up around the knee. A good physical therapist can do a really good assessment of a patient, analyze their gait mechanics and see if there's some things that they can work with the patient on in terms of improving their gait. They can work on some range of motion exercises. They have some treatment modalities they can do, like ultrasound stimulation, something called ionophoresis, where they use a combination of ultrasound and maybe some topical corticosteroids and that kind of thing. So there's a lot of different modalities that they can do to help. I think for a short term, amount of time, so like 4 to 6 weeks, I think that can certainly help patients with maybe not getting rid of the pain completely, but dialing it down, several notches so that they can get back to doing the things that they want to do.
So what is the end point of that? So if they've done physical therapy for, let's say, 6 weeks and they feel a little bit better, and they can get back to normal living, right? Do they have to maintain that physical therapy indefinitely, or does the physical therapist just give them hints as to kind of what to do on their own? Like, what is that? If it's successful, let's say, what's the next step?
Yeah, then it becomes like brushing your teeth. It's something that you have to do on a daily basis to maintain those gains that you made with physical therapy. So doing the exercises that you learned in therapy to do your quad strengthening, your hamstring strengthening, stretches, practicing the proper gait, how to get up from a seated position in a chair properly, how to go up and down stairs, all those things are really important and can make a big difference.
Got it. So it just becomes part of their daily routine where they kind of now can do it on their own.
Exactly.
One of the things you mentioned in the context of physical therapy were injections. And so like what most, lay people know of injections, like for instance, they know cortisone shots, right? And people have heard of cortisone shots in the knee. Is that for kind of just a fix, like to get better over the next few weeks? Is it something that's maintained over time? Like, what is the usual process with cortisone shots for the knee pain?
Yeah, so cortisone shots have been around for a long time.
Yeah.
Kind of one of the workhorses of injection therapy for knee and hip arthritis, and we use them quite a bit in orthopedic surgery. Basically, what the cortisone is a very potent anti-inflammatory. So instead of having to take huge doses of ibuprofen to get the same effect, we can deliver a very concentrated amount of a potent anti-inflammatory into the knee joint, and it stays there for a while. And people can see a significant reduction in the inflammatory response in the knee. So if they have sort of acute on chronic pain, the cortisone injection can really reduce the inflammatory levels there. I use it a lot in my practice for people who are coming in that have chronic osteoarthritis and say, my knee's just acting up, it's starting to hurt more, and I'll give them a shot. And sometimes it lasts a few months, 3 months. I've had some patients where I give them a shot and I don't see them back for a year, and they come back saying, yeah, it lasted a long time, and then it started.
It's reasonable, yeah.
I would say on average, though, most cortisone shots last somewhere between 2 to 3 months and then start to wear off. So it's a good option for short-term fix. But if we're talking about somebody with more advanced arthritis and they're bone on bone, and the idea of knee replacement is starting to come up, I'm not a big fan of trying to have that patient use the cortisone as a way to treat their arthritis for months or years on end. I think that's expecting too much of the cortisone.
That was going to be my question. So it's not like, okay, the last 3 months, so I'm just going to plan to come in every 3 months to the orthopedic surgeon, get my cortisone injection, and go on my way. That's not really the purpose of it, right? For this indefinite treatment for cortisone every 3 months.
Correct, because as you know, in anything in medicine, there's always a risk-benefit ratio. The risk of a cortisone injection is quite low, but anytime we put a needle into a joint, there's always a very small risk of introducing an infection. It's
Right.
quite low, particularly if somebody who's doing it has done a lot of them and is skilled at doing it and uses proper sterile technique. The chance is extremely low, but it's not zero, and there's
Right.
always a small chance that. And there's always a small incidence of patients who get this kind of flare up of inflammation from the cortisone shot itself. So you've probably heard of some patients describing this where they get the cortisone injection and then 24 hours later, all of a sudden the knee becomes even more painful. It happens infrequently, but we do see it from time to time. And it then will calm down, but it can take several days for that to occur. And it's a little disconcerting for us as the physician, but even more disconcerting for the patient. But that's rare. But the other thing is that the cortisone itself, if done repetitively for months on end, can weaken some of the structures around the knee, so ligaments, some of the soft tissue. So you don't want to be doing it indefinitely. That's just not a wise idea.
No, that's a really important point. Another thing I hear a lot about injections, another type of injection I've heard anyway, was platelet-rich plasma, or PRP. I know it's kind of it's been the hot thing for a while. Can you explain what that is and kind of what your thoughts on it are?
Yeah, so PRP is basically what we call a biologic injection. It's taking a patient's own blood and spinning it down so you concentrate the platelets in their own plasma and then re-inject it into the knee. And the thought is that it helps stimulate some of the growth factors in the knee that might help stabilize some of the cartilage cells and reduce inflammation. It's been around for a while. It's, as you mentioned, it's gotten a lot of press, but similar to a lot of the other things that we've talked about, the data is mixed. There are some studies that may show, a statistically significant difference when you look at some of the scoring systems that we use when we compare PRP injections to, say, a placebo, or maybe even some of the other injections we haven't talked about, which is the hyaluronic acid injections.
Yeah.
But there's no clinically meaningful difference between those. So I see a lot of patients that come in and tell me they've tried it and they didn't really feel it makes a difference. Now, that's somewhat of a biased view because I'm a joint replacement surgeon. They're coming to me
because they wouldn't be coming to you if it worked, right? Yeah.
So I don't know what the denominator is, of all the patients that have PRP injections, that the ones that are doing well. But if you look at the data, like I said, it's mixed, and the large scale studies really, it's kind of hit or miss. And I rely a lot on the guidelines put forth by the American Academy of Orthopedic Surgeons. And at this point in time, it's not something that is endorsed by the American Academy of Orthopedic Surgeons. So in my practice, I don't use it. There are a lot of my colleagues who
Mhm.
offer it to patients, and it's one of those things that's out there, and I would say it's kind of plus minus.
Got it. And you met that. I actually thank you for reminding me. I was going to ask you actually about I cannot say it, hyaluronic acid or visco supplementation. What is the theory behind that?
Again, nobody knows exactly how the injections work. There's some thought that it's just merely helping relubricate the joint, increasing some of the synovial fluid production. There's some theory that it helps stabilize some of the chondrocytes or the cartilage cells from degenerating even further. But nobody really knows exactly the mechanism by which it works. That being said, I use that a fair amount in my practice for patients who are kind of on the fence. They're not quite ready to talk about surgery, but they want something to help them. And I would say probably about 60–70% of the patients I give the injections to have some degree of a favorable response from the
Mhm.
injections. So they notice the knee doesn't hurt quite as much as it did, and they can see those effects lasting for 6–8 months,
Mhm.
and then it kind of wears off, and then they come back and I'll do it again.
Got it.
Usually after about 3 rounds of those injections, I start having a more serious discussion with the patient about the need for surgery, um,
Right.
and then we go from there.
Yeah, it makes sense. It sounds like basically the take-home message for injectables is that they might provide a fix, they might be beneficial, but it's none of them seem to be a true long-term solution.
Yeah, as I tell my patients, it's a temporary treatment for the symptoms, but it doesn't treat the underlying cause of the problem, which is that the arthritis has become so severe that the bones are rubbing against one another. The cartilage is really deteriorated to the point where it's just either gone or almost completely gone.
Got it. Um, which leads us to the next topic, which is your bread and butter, which is, the time to when everything else has failed and it's time to go for surgery. It's time to get to the underlying problem to fix the knee, which is surgery for knee pain. What are the common surgeries for knee pain? I know, I mean, I know it's a little bit out of boundaries to go over every type of different surgery, but what are
Yeah.
like the most common surgeries that you perform to help people with knee pain?
So the most common surgeries when you talk about knee surgery are, an arthroscopy, some sort of minimally invasive surgery where you're just making these teeny little incisions and putting a camera in the knee,
Mhm.
to joint replacement surgery, which is those are probably the most common.
Mhm.
Uh, a generation ago, it was popular to talk about osteotomies around the knee. So if somebody had, particularly a younger person, had developed arthritis in just one compartment of the knee,
Mhm.
we could perform an osteotomy, which means cutting the bone and then realigning the bone so that you're now redistributing the forces across the knee so say for instance you have bad arthritis in the medial or inside compartment of your knee. Those
Mhm.
patients tend to have what we call a varus deformity or a bow-legged deformity.
Mhm.
And if you drew a mechanical axis from their center of their hip down to the ankle, that mechanical axis would fall to the medial side of the knee so that all the stress is along that medial part of
Right.
the knee. And
Mhm.
if you do an osteotomy and correct the tibia, you can now reorient the mechanical alignment. So now it's falling down the middle of the knee and taking some of that stress off the middle of the knee. So that's
Okay.
an kind of an older school type procedure. It's really not that popular anymore. It's fallen out of favor.
Mhm.
So it's been really replaced by more what we call like a partial replacement, which
Mhm.
is replacing just one compartment of the knee.
Mhm.
So those are kind of the differences in the types of surgery. For arthroscopic surgery, it's really more for patients who have like a meniscal tear,
Mhm.
and we can clean up the meniscus, shave away that torn portion of the meniscus, or in some situations, we can actually repair it. It
Mhm.
depends on the location of where the tear is and whether there's a good blood supply to the meniscus that can allow it to heal. But for patients who come in with pretty significant arthritis where they're already bone on bone, we try and stay away from arthroscopic surgery because we now know from large scale studies that when you do an arthroscopy on somebody with bad arthritis, it actually accelerates the arthritic process and they
Really?
actually get worse quicker. So we try and steer patients away from that kind of arthroscopic clean out. Patients come in and ask for that all the time.
Mhm.
We have to have a discussion to educate them on why that's not such a good idea.
That's actually great to know. So for those patients, you go more towards open surgery and like you said, a partial or total knee replacement at that point, right?
Correct. Correct.
So when doctors say knee replacement, what do you mean? You're putting a bionic knee in? What is that exactly?
Yeah, well, it's a great question. I get asked that every day.
I bet.
Just the term knee replacement conjures up all kinds of thoughts of cutting way up in the femur and the tibia and taking the whole knee out and putting in
Yeah.
like a bionic knee. The better term would be a knee resurfacing because that's really what we're doing is we're basically resurfacing the ends of the bone. So on the femur, we're just basically sculpting the end of the femur to take away whatever small amount of remaining cartilage and maybe about a centimeter of bone. And
Mhm.
then on the top of the tibia or the lower leg bone, we're taking about a centimeter of bone and cartilage off. And we're putting metal caps, so to speak, on the ends of those surface. And then in the middle, we're putting a plastic liner so that
Mhm.
we're basically recreating a very smooth surface for the knee to articulate the surfaces against each other so that there's not that rough surface like there is with the arthritis. And at the same time, while we're doing that, we're trying to realign the knee. So a lot of patients, when they develop severe arthritis, they develop these deformities, either a bow-legged deformity like we talked about, or a knock-kneed deformity where it goes the other way, what we call a
Yeah.
valgus knee. And in those situations, we have to reorient the alignment because we don't want to leave their knee deformed because then the implant will have a higher chance of loosening earlier and fail earlier. So we really want to get the alignment right. And at the same time, with all that, we're trying to balance the soft tissues. So the tension on the medial side is equal to the tension on the lateral side, so that also helps with the stability of the knee and the ability to get the full range of motion and helping with making sure that the implant wears appropriately.
What sounds like a lot of finesse and a lot of nuance there for sure. It's not just kind of, rip it out, put it in. That's for sure.
Yeah, no, it's definitely an art form. Although we now have gotten into the era of robotic assisted surgery, which has really taken it to a whole new level where we have a robot, much like in urology with robotic assisted prostatectomies, we're now using a robot to help us with hip and knee replacement surgery
That's
to
awesome.
enhance the precision and the accuracy of all this.
Yeah, I've heard about that. That's really awesome. So I'm not sure. Well, there's a couple of places I want to go with this. First of all, I guess, how long if you're talking about a knee replacement, how long does that usually take on average?
On average, about an hour and 15 minutes, an hour and a half.
Does it require people to be hospitalized or can they go home the same day usually?
So we're at the point now where people who are relatively young and healthy and don't have major medical comorbidities, we're able to discharge those patients the same day.
Oh, wow.
So come in the morning and you can go home that afternoon. It's not for everybody, but for a small subset of the patients, we can do that. Right now, I would say it's probably about 30 to 40% of our patients are going home same day. Otherwise, patients are spending one night and going home the next day. And on
Mhm.
rare occasions, for some older patients who are over 80 and maybe have other medical conditions, we might keep them 2-3 nights depending on how they're doing.
Got it. And usually it requires general anesthesia?
Now, typically these are all done under regional anesthetics, so meaning a spinal or epidural
Oh, great.
anesthetic. combined with a nerve block. We utilize what's called an adductor canal block, where the anesthesiologist will place a small catheter into the adductor canal where the saphenous nerve runs, and we'll leave that in for 72 hours. It's attached to a pain pump that slowly infuses local anesthetic. So that's really made a big difference in terms of the pain control after a knee replacement.
Also, it's kind of like the equivalent of an epidural, basically, but locally into the nerve.
Well, they get it, like I said, they get a combination of a spinal plus the adductor canal block, and then some sedation. Most patients are in kind of that twilight sleep, so they're not having a general anesthesia with an endotracheal tube, but just sedated. And most patients don't even remember anything of being in the operating room, so it's a very pleasant experience for them.
Awesome. Now I'm going to ask you a question that to tell me something that you say 10 times a day to patients, and you probably can do this blindfolded and half asleep. Doctor, what are the risks of this surgery?
Well, the two things that we worry most about with joint replacement surgery are infections and blood clots. Those are the big things we worry about. The risk of infection after a knee replacement is probably on the order of about 2 to 3%. That's kind of the national average. Which, if it does happen, it can be a big problem. But we're very meticulous with, how we, keep the OR environment, try to be as sterile as possible. As you can't make the OR completely sterile, but we try and keep things as clean as possible. We wear special spacesuits that help decrease, any shedding of microscopic particles that can get into the surgical wound. We give antibiotics before and for about 24 hours after. And a lot of it is technique dependent. So, making sure that you're not taking too long with the surgery. We know that surgeries that take, more than 2 or 3 standard deviations of time beyond what's considered the average, those have a higher risk of infections. And then patients with various medical conditions are also at greater risk for infection. So patients who are obese, patients who are smokers, and then patients, who are like diabetic with poor glucose control, or patients who are immunocompromised. Those are all patients that are at greater risk for infections. So there are things that we can control and some things that we can't control, but we try and optimize the patients ahead of time to really make that risk of infection as low as possible. And then the other thing is blood clots, like we mentioned. So blood clots are always a small risk after knee and hip replacements. As we've gotten into the more rapid recovery phase over the last several years, with patients getting up and walking much more quickly, like a few hours after surgery, the risk of developing a blood clot or a DVT becomes much less. A lot of the data on DVT occurrence is based on older literature when patients were staying in the hospital 7 days and not getting up for physical therapy right away. So in this more modern era, the risk, I think, is lower, but it's not zero. And so we put patients on some form of a blood thinner after the surgery. In this day and age, if a patient has had no previous history of a blood clot, we're usually putting patients on a low dose aspirin twice a day for about 4 to 6 weeks after the surgery. And that's been shown to be as effective as preventing blood clots and pulmonary embolism compared to some of the more traditional anticoagulants like Coumadin or Lovenox. We try and stay away from those types of agents because those have a much greater risk of bleeding at the operative site, which we want to avoid. Now, if a patient comes in and they've had a previous history of a blood clot, or they're already on a blood thinner before the surgery, say for atrial fibrillation, or they've had a history of many blood clots and they're on chronic blood thinners, then we have to pay close attention to that and then put them back on a blood thinner after the surgery. So those are the two big risks. And then there's other lesser common risks like just the stiffness of the knee, patients not getting full range of motion after the knee, fractures around the knee, ligament injuries,
Mhm.
problems with the skin healing. Um, those are the nerve injury. Those are all very rare, but things that we mention to patients beforehand.
Good to know, but it sounds like two biggies for sure.
Yeah.
Now, when I wake up from a knee surgery from knee replacement, how much pain should I expect, both immediately and kind of in the course of the next couple of weeks?
So immediately upon waking up in the recovery room, most people are actually quite comfortable because they've got that block in
Yeah.
place. We also administer what's called a periarticular injection at the end of the surgery. So after we've put all the implants in, but before we start suturing up the knee, we inject a cocktail, so to speak, or in the soft tissues around the knee. That's the combination of a short-acting and long-acting local anesthetic, plus an anti-inflammatory and even a small dose of a corticosteroid to help with decreasing inflammation. So the combination of those two things really helps make patients feel really comfortable when they wake up from the
Mhm.
procedure.
And do they need a lot of pain medicine, like when they go home and like for the next couple of weeks, or it's pretty moderate, mild, moderate?
So knee replacements definitely are known to have a considerable amount of pain after the surgery once the block is worn off, once they take that catheter out at the 72-hour mark. So it's can be sometimes shocking to patients that they're having pain, but with the right combination of pain medications and anti-inflammatories, icing techniques, elevation, we can really keep the pain under control and get them through the process. On average, I think the more significant pain is during the first couple weeks, and then it really starts to ratchet down.
Mhm.
But I always tell my patients, it generally takes about 3 months to completely rehab the knee and get through the whole recovery phase. And
Mhm.
even at that, I tell patients at 3 months, you're probably about 95% of the way recovered.
Mhm.
To feel like you're 100% recovered, I think takes a full year. And that's where patients can get a little frustrated because I see patients back 3 months, then 6 months, and at that 6 month mark, they're off pain medications, they're back to playing golf or hiking or cycling or doing all the things they want to do, but they're still reminded that they had the surgery. They
Mhm.
have some, if they do a little more, you know, in their activities, they might have a day where they feel a little more pain, it might swell a little bit, or sometimes they complain of the knee feeling a little mechanical. They might feel a click or hear something in there moving around, and that's because it is an artificial knee. It is metal and plastic, so they can
Yeah.
feel that and sense that. And I think it takes about a year just to kind of acclimate to that whole notion that this is a mechanical knee that I have in there.
Got it. Got it. That's great to know. Now, I think you mentioned already that people are walked like out of bed the next day. They're not like bedridden, right? Or are they still?
The same day. I mean, like for the
Mhm.
patients that we send home the same day, I mean, the physical therapist comes and sees them in the recovery room, literally, an hour and a half after they're, fully awake and ready to go. We get them up and they're walking up and down the hall. We even have them go up and down stairs, you know, before they leave that same day. So they're getting around right away.
And do they, I think you mentioned this as well. Do they get physical therapy? Like, does every patient who have knee replacement need physical therapy for a period of time to get back in the swing of things?
For knee replacements, yeah, I think it's a very critical part of the recovery process. So, I personally recommend therapy for all my patients after knee replacement surgery. There are some surgeons out there who, are starting to go away from it, but I still think it's a very critical part of the recovery process. For hip replacements, most of us have gone away from therapy after a hip replacement because it's really not necessary. But for
Mhm.
the knee, I still think the patient really benefits from working with a therapist to help them really bend the knee and work on getting full extension, uh, you know, to walking. And, a lot of patients use a walker for the first week and then transition to a cane. And I think the therapist can help guide them in that process. And when to transition, and then when it's okay to get off the cane. So I really rely on the therapist to handle that part of the recovery process.
Now, a lot of question that commonly the patients ask is that, assuming I'm not LeBron James and I have a desk job, when can I go back to work usually?
People with desk jobs, which are probably the majority of my patients, it's really when they feel comfortable getting back to doing that. I've had some patients who are back doing a desk job within a couple of days after the surgery, because they can work from home, they can be on the computer. You have to be careful, because the knee and the leg will tend to swell. So if you're all of a sudden trying to sit at your desk for 6 hours at a time, it's not going to be good for the knee. It's going to swell and become painful. So
Right.
you have to be smart about it and break it up into very small increments, but it is doable. The other common question I get asked is, when can I drive after surgery?
Yeah.
If it's the right knee, which we use to go from the gas to the brake, we usually tell patients you should probably wait about 2 weeks before you get behind the wheel. We used to recommend a longer period of time, but we've had some more recent studies to show that the reaction time of going from the gas to the brake is actually pretty normalized by about 2 weeks.
Got it.
But if it's the left knee, it's really once patients are comfortable getting in and out of a car and they haven't taken a pain pill within 4 hours of getting behind the wheel.
Got it. And you kind of preempted, you said that 3 months is kind of I guess what you quote patients are like recovery time. Obviously it can be longer, but generally that's the general recovery time. Am I to assume that that's around the time when you start exercising again, like can go back to the gym, or is that too soon?
No, I actually tell people they can start, doing exercise, like riding a stationary bike, walking, doing the elliptical, as early as they feel comfortable doing those things, because those things will help with regaining the full range of motion of the knee. Now, it has to be done in a graduated fashion. You don't want to just post-op day 2 just get on a bike and start trying to ride.
Tour de France, baby.
I've had some patients do that, and they come back and the knee is swollen up. So we try and educate them to do it slowly. But no, they can start doing activities like that, pretty early on. 3 months is when I basically say, you're good to go. Go, just do whatever you feel
want,
comfortable doing. But they can start doing things much earlier than that in the recovery phase.
Got it. One last question about the actual recovery, I guess the prosthetic itself, the knee replacement. What's the lifetime of that? I mean, is that for life, or do you expect in 10 or 20 years you have to get it replaced? What's the general thought about that?
Yeah, so the average that we tell patients is it's going to last about 20 years. That's if you look at large scale studies and looking at all the implant data out there, 20 years is a good estimate. Now, some people longer, some people less. A lot of it has to do with how well the implant's put in, as well as patient factors like their activity level. It's kind of like the tires on a car. If you only drive your car from your house to the supermarket once a week, you're putting very low mileage on. It's going to last a long time. But if you're taking your car out and going off-roading, every weekend, you're going to wear things out a lot sooner. So, it's all about averages, but 20 years is about the average.
Got it. And moving away from the surgery, and just a couple of questions about the surgeon. Now, with you, it's pretty easy, but not everyone is the chief of joint replacement at one of the best hospitals in the world. When you are a guy looking for a surgeon or evaluating surgeons, this is a big, as I've learned from you, this is a nuanced operation. This is not just kind of rinse and repeat. What, as a patient, should I be asking for or looking for in a prospective surgeon? Is it just experience? How many years they've been doing this? Is it specialization? Is it number of cases? What should I be looking for in a surgeon to do my knee replacement?
Yeah, well, I think it's a lot of those things. I mean, certainly experience is probably the number one thing. I mean, just like in anything in life, when you do something over and over again, you become quite good at it. I mean, the 10,000 hour rule was not, from out of thin air. I mean, there's a real science behind that. So I think, finding a surgeon that does a lot, is important. I mean, if, as a patient, you ask your surgeon how many you do a year, and they say, "Oh, I do 1 or 2 a year." It's probably not the
Right.
probably not the
I
right
dabble.
person to do it. Probably, anywhere from, 100 or more a year is probably something that's quite reasonable.
Mhm.
So I think, somebody who has a lot of experience now, there are people that come out of training and are very experienced right away because in their training they've done a lot of them. But also years in practice also plays a role. So somebody who's, just fresh out of training may not have the experience of dealing with certain unexpected things that happen during surgery, whereas somebody who's been in practice for, 15, 20 years is going to have, a lot more experience on how to get out of that situation and handle something that might, come up unexpectedly.
Got it. No, that's actually great advice. And you had mentioned like robotic surgery. I mean, is that a must? Like, if is that a question that should be asked, or is it not that mainstream that it's like critical for success?
Well, it's becoming more popular. I certainly wouldn't say it's mainstream at this point, and we don't have any data yet to show that it makes the overall outcome of the knee replacement any better. We do have some studies that show that the overall limb alignment can be more consistently reproduced with some form of either robotic assistance or navigation assistance. We do have data to show that, but whether that truly means the knee is, perceived to be better by the patient, we don't have enough data at this point to say. So I don't think that that's a must. I mean, I feel like personally, I can still do a very good knee,
Mhm.
without the robot. But it is becoming part of our reality, not just in medicine, but in other industries. And we drive our car, we have the computer helping us get from point A to point B, because not that we necessarily need it, but it does help enhance the overall experience.
Awesome. Well, Dr. Zeegen, thank you so much for all of this amazing information that you provided. I'm going to end with one final question, completely unrelated to knee replacements.
Sure.
Something I ask all our experts on the podcast. And that's like, aside from being a successful surgeon and knowing everything there is to about knee replacement, you're also a successful person. And, one of the name of this is Better Man Clinics, getting guys to be better. What's your secret to your success about living your best life?
Well, I think it's just, really taking things one day at a time, and being in the moment and appreciating, all the things that you have in your life. I'm fortunate enough to be married and have 3, great kids. And, that's not to say it's always easy, but, they are all truly a blessing. And I think, just, not getting caught up in the small stuff and just focusing on the really, good stuff helps me stay grounded and appreciate the day-to-day stuff. So for me, that's my way of dealing with it. I don't know if that's for everybody.
I think that's as good advice as any for this. And again, thank you so much for joining us. And for everyone watching, thank you. And remember that, as we say after every episode, your best life is a journey and not a destination, and use every day to make your life just a little bit better. Thanks, and we'll see you next time.